Well, good afternoon. So we'll keep going with common intracranial infection. So again, it's going to be quite a kind of list. I don't have any trick to give you the way to remember this list, but let's say we'll go through bacterial leptomeningitis. We'll go through tuberculosis, listeria, Lyme disease. For virus, we'll only focus on herpes virus. On parasites, only on cysticercosis, and fungi, very shortly. We'll review this very, very briefly. One word on Creutzfeldt-Jakob disease, which is a prion infection, and a small thing to know on MERS syndrome. Then, what about the common bacterial meningitis? Actually, most common germs involved in meningitis are Streptococcus, Neisseria, and Haemophilus. Sometimes it can be other germs like Staphylococcus or even coli or whatever. Usually the spread is hematogenous, but sometimes it's regional through a nasosinusal infection or through surgery. And usually at that time, you'd rather have pachymeningitis rather than a leptomeningitis. The presentation is quite similar across the disease. You have headaches, fever is common, neck stiffness too, and sometimes because of hydrocephalus, for instance, you may have intracranial hypertension with nausea, vomiting, and papillary edema. The diagnosis can be confirmed by lumbar puncture and analysis of the CSF. Since the severity of this disease relies mainly on the hydrocephalus, the occurrence of ventriculitis, empyema, and intraparenchymal abscess. Sometimes you may have some vascular complication. To make this point very clear, we just have to remember the organization of the meninges in the brain. You remember here's the central nervous system, then whatever the brain on the spinal cord, it's always recovered by the pia. In between the pia and the arachnoid, you have some CSF where you have some vessels, some veins, some artery, and the arachnoid recover the deeper layer of the dura. And the dura, then you have classically two layers, one deeper layer, the dura mater properly, and the external dura mater, which is rather like the periosteal involvement of each bone pieces. And in between, sometimes you have some sinus, venous sinus. And when we talk about leptomeningitis, usually it's an infection of the pia, and we really see nicely an enhancement of the pia. Of course, the arachnoid may enhance, but usually it's not as thick as the pachymeningitis, where the dura is involved. So about imaging, then leptomeningitis relies mainly on leptomeningeal thickening, on using 3D T1 post-contrast, for instance, or 3D flare post-contrast too. I mean, the sensitivity is increased after contrast injection. You may see an abnormal filling of the cerebral sulci here. You see, normally you should have only dark signal related to water, whether on the T1 or on the flare image. And you see this linear enhancement along the sulci is due to the infection and the inflammation of the pia at least. Then here it was a simple example of leptomeningitis due to Streptococcus. And sometimes you may also have a pachymeningeal thickening, but it's not always so obvious. You see here, for instance, you don't see a real thickening of the pachymeninges, then you can have isolated leptomeningitis. You have to keep very clear in mind that the sensitivity of brain imaging to diagnose infectious meningitis or whatever it causes is very poor, and it's also very poor to predict what kind of germ is involved. But anyway, each time you see an enhancement of the cell chi, you may state that there is a leptomeningeal abnormality, and it could be due, this inflammation could be due to an infection. Of course, it's not only the only cause. Infection is not the only cause of leptomeningitis. It can be also due to systemic disease like sarcoidosis, of course, or carcinomatosis secondary to a metastatic process. Pachymeningitis can be also has to be distinguished for normal reaction after a lumbar puncture and other granulomatous disease such as histiocytosis or again carcinomatosis. Besides this classical bacterial leptomeningitis, you have other bacterial disease such as tuberculosis. It's quite a rare location as brain, and the CNS is quite a rare location of tuberculosis. But when it occurs, it may really worsen the prognosis of the patient. Usually the diffusion is hematogenous, and it associates usually leptomeningitis with granulomas or abscess. The clinical presentation is absolutely not specific. I mean, you have a meningeal syndrome, sometimes intracranial hypertension too, but you may also have some focal signs due to tuberculoma or to cranial nerve palsy, for instance. Then what is very suggestive is this very thick basal leptomeningeal abnormality. You see here, normally it's a FLAIR image, post-contrast, and you see that all the subarachnoid space are replaced by an abnormal high intensity due to the leptomeningeal thickening. It's obvious on the post-contrast T1. You see the enhancement of the pia around the midbrain, and here a thick involvement of the interpeduncular space. Then again, to really be more sensitive to the leptomeningeal involvement, please use those 3D FLAIR post-contrast and 3D T1 post-contrast as well. That can be modified using spin echo sequence. Besides this leptomeningitis involving the basal area of the brain, you may have what is called tuberculoma or tuberculous granuloma. It's a granulomatous reaction to the germ and leading to a caseous necrosis, sometimes to real abscess. On CT, it's not specific at all. You see a round hypodense lesion. Sometimes can be slightly hyperdense. The ring enhancement is not specific, and calcification are very rare. MRI are also very poorly specific. You can see this rim-like enhancement. On diffusion, sometimes you have restricted diffusion, sometimes it's high. It depends on the content itself. What's interesting is you may have, again, this target appearance on T2 or on diffusion image, revealing this, the history, the natural history of the abscess. What is quite striking among all those signs is, remember, there's a thick leptomeningitis of the basal area of the basal cistern, and with this abscess-like lesion. Sometimes it looks real like an abscess, sometimes it's only a granuloma. Perfusion is not very helpful. You will see only an increased permeability, but not an increase of perfusion probably, and it allows you to distinguish this mainly from tumoral process, and spectroscopy is very suggestive when you have also a very high peak of lipids. Then what is really important in all those diseases is not trying to gamble on the germs that could be responsible of the meningitis. Sometimes it's only to rule out hydrocephalus and intracranial hypertension in order to allow the lumbar puncture. When there's any sign, clinical sign of intracranial hypertension like nausea, vomiting, and obviously with papillary edema, it's better to perform first CT, at least CT, to rule out any hydrocephalus that could be responsible of intracranial hypertension, for instance. And here you see many different kind of etiology responsible of here above pachymeningitis, here after a lumbar puncture, here a lymphoma with a combined pachymeningitis and a leptomeningitis, here a rheumatoid arthritis, here a neurosarcoidosis looking quite similar to tuberculosis, and here another case of leptomeningeal carcinomatosis, very suggestive, very similar to tuberculosis as well. Then gambling on the nature of the germ below the enhancement or the inflammation of the meninge could be funny, but it's not real medicine. In practice, you really need to have a sample of the CSF to do the right diagnosis. What about the bacterial abscess? This is one side effect of all this infection. Of course, it's rare but life-threatening disease. It may occur in immunocompetent patients, especially with those germs we talked about previously, Streptococcus, Staphylococcus, and so on. The location of the germ, the abscess depends on the way the germ was spread. When you have a regional spread, like after a sinusitis or head and neck infection, it's rather skull base. When it's hematological spread, it's rather in the deepest brain area. The clinical presentation is not always helpful. Fever is quite inconstant. But of course, when you are close to eloquent area, you may have seizure or focal neurological deficit. What's interesting on imaging is that it's quite easy to recognize a bacterial abscess. We'll see some image. Maybe here it's easier on this image. You see on CT you will have a round mass. With a dark, hypodense necrotic center, which is surrounded by an enhancement, peripheral enhancement. When you look carefully on the non-enhanced contrast, non-enhanced CT, you may see slightly hyperdense rim due to the capsule, and of course you always have a large edema. An abscess, they always have a large edema, and usually the mass effect of the lesion is not only due to the abscess itself, but also mainly due to the surrounding edema. On T1, you will see also this capsule, as on T2, due to the free radicals accumulation, as a hyper-intensity on T1, slightly hyper-intense, and slightly hypo-intense on T2. Okay? On post-contrast, you will see a peripheral enhancement, and if you do perfusion imaging, usually it won't, you won't demonstrate any hypervascularization, only an increased permeability. Of course, beside all those signs, and that's now what makes the diagnosis easier, you have a diffusion imaging that will display a restricted diffusion into the necrosis of the abscess. And you have first the capsule to analyze, and of course the necrosis. And the necrosis has a very high signal and diffusion due to a reduction of the diffusion into the pus. Spectroscopy can also be quite interesting by demonstrating some specific content into the necrosis. Actually, you have some acetate here. It's a 1.9 ppm. It's not 2 ppm. You have to distinguish this from NAA, which is normally quite beside. Then you won't find any NAA. You won't find any choline. You won't find any creatine. You will find some acetate and also some amino acid at 0.9 ppm. And of course, lactate, which are very poorly specific. And beside this bacterial abscess, remember, you may have some rather specific disease like Listerioid rhomboencephalitis, which is due to a germ, a bacteria that can be found in milk product, poorly cooked milk product, or poorly cooked delicatessen. And actually, now with the organic fashion, we start to see a little bit more, especially in my area where people live in a close relationship to nature. Actually, well, having a listeriosis is quite rare. We didn't see so many, but it can be really at risk, especially in pregnancy. Anyway, it's one of the most common etiology of rhomboencephalitis, and the mortality is really high. What about the clinical presentation? Of course, febrile headache won't help you very much. But once you have cranial nerve palsy and also brainstem disorder and cerebral disorder, you may have to think about it. The proof will be given by the lumbar puncture, and imaging will demonstrate the rhomboencephalitis involving the midbrain, the cerebellum, and the pons. And on the MR, you will see this involvement here of the pons, here a little bit on the medulla as well, which is absolutely not specific, but on T1 you'll see this little abscess, and what you keep in mind is having a lesion, an inflammatory-like lesion in this area. You don't have so many diagnoses, then first always think on listeria. Then once you suggest this, it's the emergency. After, you can talk on Beset disease or other antibody autoimmune disease, but usually first always think on Listerioid rhomboencephalitis. Another quite suggestive disease is the neurolyme. It's also a bacteria, Borrelia, due to a tick bite. And you have several phases. First, usually is a cutaneous phase after the tick bite. And after start the neurological symptoms. And according to the length and the duration of the symptoms and the way it can recover or not, you will start to deal with phase 2 or phase 3, including joint disorder and cardiovascular disorder. The lesions themselves can mimic into the brain, can really mimic multiple sclerosis. But what is quite suggestive is when you have a leptomeningeal enhancement along the cranial nerve. And we'll see a little example here. You see, then you have some little hyperintensity. It doesn't, it's not specific at all. It could look like microangiopathy or sometimes to MS. But what's suggestive is when you start to have cranial nerve enhancement. And here, for instance, you have the oculomotor nerve, number 3, here and here. Here you have trigeminal nerve on this side. And here you even have an enhancement of the abducens nerve, number 6. Okay, so this little enhancement that can be nicely demonstrated whether using T1 post-contrast or FLAIR post-contrast is easier when you use 3D volumic sequence. Viral infections, and let's focus only on herpes virus encephalitis. It's a very dangerous disease. People don't always have fever. They usually have confusion. Headache is quite inconstant, but sometimes it can mimic stroke because the onset can be quite acute. But it's not always very clear to rely on the patient history and so on. Then what you have to think of is when you see this the anterior temporal abnormality involving at least the anterior part, when the amygdala, and obviously when you have the amygdala and an additional part, it's not usually a stroke. For instance, amygdala rely on the vascularization of the anterior carotid artery, hippocampus of the posterior cerebral artery, and the lateral part of the temporal lobe on the middle cerebral arteries. And you have 3 different arteries involving this area. Then it's always possible to have a stroke, but first you have to think of herpes meningoencephalitis. It's going to be very, very helpful, and in any time you have to think about it, you have to warn the medical doctors or the emergency ward to put the patient under treatment. And then, even if you do, you see this kind of image on CT, they don't have to wait for MR to rule out definitely that it's not a stroke to start the treatment. Microbleeding are possible. It's a classical feature on the pathology. We used to say that it could be a necrosis with hemorrhage, but in practice it's not that constant, and as well as leptomeningeal enhancement is really not constant. Then what you have to think is when you see an anterior temporal lesion involving the internal part of the temporal lobe, you have to think on herpes meningoencephalitis, and after you may have some additional involvement of the, for instance, the pulvinar area. You also have some cingulum area and insular area as well. Here is another case. It can be bilateral with quite severe sequelae, and you see here you have the amygdala, it's one vascular territory, the hippocampus, another one. Here's the temporal pole, is another one. Then it's not a stroke, especially when it's bilateral. This is herpes meningoencephalitis until the biology say it's not, and then it can be something else. It can be autoimmune or whatever. Okay, spectroscopy can be quite helpful. Especially when you start to discuss with low-grade glioma, infiltrating low-grade glioma. Spectroscopy will show you, well, lactate, it's not that helpful. You will see a decrease in Na, is not that helpful, but you won't see a very high increase in choline. You see the ratio between choline and creatine is very close to 1, and then giving this diagnosis of glioma less possible. Okay, something maybe you know or is the MERS. MERS is a mild encephalitis with reversible splenial lesion. It's not something that, it's something you have to see once in your life, and maybe you have seen already before. It's this little hyperintensity usually in the posterior part of the corpus callosum in the splenium. And you see it can be quite edematous with a hyperintensity on T2, but it's not always very clear on T2 or flare, and usually it occurs after an infection in virus, but also in other bacteria. The outcome is really good, but you just have to have this image in mind, and especially when you see this image on diffusion. It can be quite frightening, but once you see this little hyperintensity, especially in diffusion with restriction of diffusion, you have to think on the MERS to ask if the patient had an infection in the day before, and then you can only describe this lesion and let the clinician keep taking care of the patient and not having a big deal with such image. Among parasitic infection, the one you have to know is neurocysticercosis. Neurocysticercosis is a very common infection, maybe not in Austria, but you see in all this area, Central America, South America, southern part of Africa, Southeast Asia, but I see that Ukraine, it seems they have quite much, and Portugal also. Well, okay. Usually the egg are into the pig, and then the pig are not cooked enough, and they are eaten by man, and then with feces, the water can be contaminated, and then you eat the egg this way. Okay, and then it can be located in various parts of the body, muscle, but including central nervous system. Here is an illustration, and you have different stage according to the evolution of the egg. What's interesting is you have to look for some calcification. And once you see this little calcification with a small spot like a granule, it's due to the parasite, the scolex, probably. And then when you see this kind of little cyst, usually dark on MR, on every sequence, including SWI, T2 star, and so on, move the patient to CT, be sure it's a calcification, and of course ask if the patient is supposed to come or to live in an area at risk of infection, and then you can suggest this diagnosis. Of course, it can mimic metastasis, it can mimic different things, but here, or even cavernoma, for instance. But when you carefully look and you see this little head of the scolex, you can be sure of the diagnosis. And finally, fungal infections are very extremely rare in patients with a normal immune system. Usually they take place after a sinusal or nasal-sinusal infection, and it's in this case it can be due to fungus like mucormycosis. Here, aspergillosis as well, but sometimes it can be very difficult to distinguish this involvement from another kind of infection. This was an infection after a trauma where you had a combined abscess and hemorrhage and so on. Then be aware that the nasal-sinusal infection can be at risk, of course, of basal intracranial infection, and then it could be a fungi as well. One word on Creutzfeldt-Jakob disease. It's usually sporadic. It has been described after neurosurgery, but now when everything is clean and sterilization is working well, then but it has been described after certain dura graft and so on, but now it's over. There was the story of the new variant, especially in England, after the bovine spongiform encephalopathy in the late 90s, which it's also a prion, but it looks quite a bit different on imaging. But it's a kind of disease you won't see anymore. This kind of disease you may see, and what you will see is abnormality into the gray matter. Then the gray matter, the cortex and the basal ganglia. You may see it on T2, FLAIR for instance, but usually you see it very nicely on diffusion image. And when you see this kind of hyper-intense here basal ganglia, you may suggest this diagnosis, especially when you have a patient, usually quite old, having a cognitive disorder and starting with muscular disorder as well, and so on. What you have to know is that the lesion can involve the basal ganglia, the cortex, they can involve both, or the basal ganglia only and the cortex only. It can be symmetrical or also asymmetrical. Then what's interesting is to think about it and to perform diffusion imaging. But now you understood that diffusion imaging should be performed almost all the time you perform MR. Okay, then what to remember again, master the patient history, clinical and biological data. When you have any sign of intracranial hypertension, you have to rule out any cause of intracranial hypertension. It could be due to hydrocephalus or abscess and so on. Actually, sometimes, most of the time, your main role will be to say, okay, you can do the LP safely, and after this, you may try to suggest some bacteria according to the location of the meningitis. Any MR, if you have difficult access to MR, should postpone the treatment, especially in herpes meningoencephalitis. The protocol is quite the same, including all kind of sequence, do the 3D FLAIR and the 3D T1 post-contrast, and don't forget to include diffusion and T2 star or SWI. And finally, remember that when you have a meningitis, contrast enhancement is very inconstant, as there's a very low sensitivity. When you have a contrast enhancement, it is abnormal, but be sure that first it's not due to lumbar puncture. And anyway, even so, you have a quite poor predictive value to define what kind of germ is under. Then your main role is to allow the lumbar puncture. Of course, when you have a basal leptomeningitis, suggest tuberculosis. Rhomboencephalitis, think of Listeria or Lyme disease. And when you have temporal limbic involvement, think of herpes virus. Cyst, always look for pyogenic cyst using diffusion. Calcified cyst, you will prove it using CT, good old CT, non-enhanced CT or T2 star, and think of neurocysticosis. And what about the gray matter? When you have a single gray matter involvement, suggest Creutzfeldt-Jakob disease using diffusion imaging. Thank you for your attention.